And failing that, you guys can just shout out, but we'll do that. So everybody good with that general gist?
Absolutely.
Yep.
Yes.
Okay, great. Well, it is nice to either see or hear a bunch of friends on here. So let's just go ahead and get started. So basically, we appreciate the opportunity to get together with everybody and sort of talk about where things are with COVID. We know that it's been very confusing lately, and that there's been a lot of conflicting information and a lot of information you either may not understand or may understand and not agree with. So our goal for today is to kind of go through all of that and try to frame it in a way that makes sense to us. And also, hopefully that will make it easier for us to make it make sense to our patients. So having said that, this is supposed to go to the next slide. There we go. And
Okay.
There you are.
And there we are. And I think this just kind of says it all. Okay. And the patients could just as well be us, but you know, we've got a patient sitting here saying I'm constantly confused, and the psychiatrist who says the patient's overexposed to CDC guidance. And I think that is sadly true for many of us. So I think a fair question for all of us would be, why am I so confused right now about what to do? And I think that while we're all very frustrated with the way that we're getting the information, I think we need to understand kind of why that's happening. And it's really difficult to give information in a way that works for everybody, and especially when you're in a very emotional situation, which I think COVID is. If you are a scientist talking to a bunch of scientists, which is a lot of the people at the CDC, scientists want details and they want guidance. They don't want to be told, do this. They want to be told every little detail, every little, you know, change in a molecule, all the details of the variants and what's different on the protein spike. And, you know, most of us don't actually need that, but the scientists really do. And sometimes feel like if they leave out something, then they're not presenting appropriately. On the other hand, those of us who are looking for action, what we really want to do is know what it is we're supposed to do. And public health officials have a different perspective. So when we're talking to each other, you know, I care what happens to Susan or Anne Marie or Kathy or the patient who's in the room, and that's what you expect of me. But and what I expect of you, by the way. But when a public health official is making a decision, they're looking at the big picture. So they're just not looking at what the grocery store workers' risk is of getting COVID. They're looking at what's the risk to everybody else if there's no open grocery store or no open pharmacy. So they are looking at this from a very, very different perspective than we typically are. And they could therefore come up with a different answer. And one of those that I think we're going to talk about later is the rather interesting pathway that the isolation recommendations took. But I think to some extent, that is a reflection of this, the balance that public health officials saw when they made decisions, which is probably quite different from how the rest of us are making these decisions. And, you know, just remember that one of the biggest public health interventions and most successful of all times was sewers. But that is not something that we all talk about one-on-one when we're dealing with personal health decision-making. So maybe that'll make that a little bit clearer. I think the CDC and the others have really managed to confuse a lot of us. And part of that is just because of this issue of academics talking to people who have a very different context. The other thing is that I think with all of the changes that have happened in the CDC, we've lost some of the people who were the professional communicators. And some of the new people really didn't know, perhaps, and this is sort of an insight from a friend of mine actually who retired from there, who they needed to talk to and how to frame the message for a broader audience. So I think that's a lot of what we've been seeing. I am frustrated and confused. I worship the CDC professionally. I have for 30 or 40 years, but I do think that they have failed a little bit in communicating adequately. And I don't think they have failed with regard to science, So I think it's a fixable problem. I would also tell you all, for those of you who don't know, Dr. Middleton, who is our infectious disease doc and who has been amazing through this whole thing, he actually knows Dr. Fauci very well. And I asked him what he thought about what was going on. And what he gave me was an incredibly powerful view of how smart Dr. Fauci is and how trustworthy and how value driven. And I've got to tell you that that made me feel a lot better, that that is one of the captains of the ships, and that we have a personal recommendation as well as the professional one about how really good he is. The other thing is that sometimes TMI is just TMI. And so if I am exposing you to TMI as we go forward, please feel free to let me know that. Okay, really simple question. Who can get COVID? And the really simple answer is anybody. And that's something that's really important to remember. You know, if somebody doesn't look sick, don't go with that. Okay. Now, there are big differences in who's most likely to get COVID. And at the top of the list is people who are unvaccinated. And that just hasn't changed. Okay. Unvaccinated and then unboosted, people who are at medically high risk, and what may or may not, in retrospect, have needed to be a separate bullet point, is people who are immunocompromised as part of their medically high risk situation because they can't respond to vaccines appropriately. So they're not exactly unvaccinated, but they can sort of behave as if they are. So that's just something to keep in mind. And finally, there are people who are at high risk because of health equity related considerations or inequity. And that's some of what's in the picture on the right there, but it's also what we at VIM live with every day. If our patients live in a world that makes them, less able to protect themselves from healthcare risks, for example, when you are in isolation, when you're isolating somebody at home because they have COVID, one of the recommendations is don't share a bathroom. Well, how helpful is that to many of our patients? Maybe yes, but maybe no. And there are similar recommendations. So it's just really important to remember that these health equity commentary and discussion, which has been sometimes a little bit amorphous, is very, very real in the world that we live in and has to inform how we take care of our patients. Who needs to be vaccinated? Well, I cheated a little bit on this slide because I think that it's going to change soon. So basically, it's not everybody, it's everybody who's eligible. Okay. And hopefully someday that will be everybody. But right now, as of January 25th, which was last week, vaccinations are available to anyone 5 and older. And I think that you should speak with very strong voice that anyone 5 and older should get vaccinated. There has not been a huge uptake in vaccinations for the younger groups for a lot of reasons, and we're going to talk about some of that later, but it is really important to vaccinate the kids, and largely because they are obviously the least vaccinated right now. I'm going to just talk quickly, and if the slides are a little confusing, we'll send them out later, but this is basically just so you guys have a reference. So there are 3 vaccines that are currently licensed in the United States. One of the things to remember is that if you read stuff from overseas, it's not exactly transferable because the vaccines are not exactly the same in other countries. Some are, some are not. So for example, Europe uses a lot of AstraZeneca, we use none because it's not licensed here. So just be aware that when you're comparing what's happening here and elsewhere, we don't exactly have the same vaccines. That said, Pfizer is the only one that is approved for ages 5 and up. For ages 5 to 15, that's an emergency use, and then it's fully authorized for 16 and up. And just as a reminder, there's a primary series, there's a booster, and the booster dose is the same for 12 and up. The only thing that is imperfect in this slide is that that is the primary series for most people, but for immunocompromised, that definition is a little bit different. And that gets confusing when we talk about boosters. But the primary series is whatever is appropriate for you and your circumstance. And for the majority of people, Pfizer, that's going to be 2. The next one is Moderna, and that is 18 and up, and you know the information. The one thing that I would tell you is that there have been some articles coming out lately comparing Moderna and Pfizer, and they've come up with Moderna works better. but there's a difference between relative and absolute changes. And so the bottom line is that if you look at how many people are actually more protected with one versus the other, it's a tiny number. And basically, in my mind, I think of them as essentially the same. But in the most recent study, Moderna had a slight statistical edge. This is from the end of last week, but I think for practical purposes, not a very important consideration. And finally, J&J. And early on, I think a lot of us were really fans of J&J because it was one shot, because the storage was easy, because it seemed like that was going to be the winner. So I want to spend a moment to tell you it is not the winner. And the current recommendations are actually to avoid J&J unless you have a really, really good reason why somebody should get it. Now, it is pretty safe and it is sort of effective. So it is way better than nothing. So if your choice is J&J or nothing, J&J is the right choice. But if your choice is Pfizer or Moderna versus J&J, it is absolutely Pfizer or Moderna. And this slide was before that study came out last week. So Pfizer and Moderna are basically about the same. But Pfizer is more available to different age groups than Moderna. So just to be clear on that. Are you guys good? I didn't confuse you with that? Okay.
Yeah.
All right. Now, boosters are also really important. And, as some of you know, there was kind of a discussion about why do I need a booster? I just got my shot and other shots don't need boosters and all of that, none of which is really true. But I think that there is a series that just came out from the American College of Physicians with some interviews with, I think, very compelling speakers addressing some of the COVID-related issues. So I'm going to turn this over to Jackie for a moment to let us all hear from Dr. Carlos Del Rio. And I will be back as soon as this is over, assuming that I could turn my PowerPoint back on. So with that, I will turn it over to Jackie and Dr. Carlos Del Rio.
Dr. Carlos Del Rio, and I'm an internist and infectious disease specialist based here in Atlanta, Georgia. Welcome to another episode of ACP Ask Your Internist Series, where physicians like me answer your top vaccine questions. There's a lot of confusing information circulating online about vaccines. I'm here to answer your questions and clear up the confusion. After you've been exposed to an antigen, to a vaccine, you produce antibodies, produce memory T cells, and the antibodies over time start decreasing. That is what we call the waning of immunity. When you get a boosting, what you're doing is reminding your immune system about that antigen. You're getting exposed to that antigen again. It's a little bit like, reminding your muscles about exercising. So when you go to the gym and do weight training, you are in a way getting a boosting on your exercise. And also because of the emergence of the Delta variant, the most important thing we can do to fight variants is to prevent transmission. A virus that is not transmitting is not mutating and therefore is not producing new variants. What we've learned is that boosting the response in individuals, you get about a 10-fold decrease in your risk of getting infected and about a 20-fold decrease in the risk of severe disease and hospitalization. And this applies across all age groups. CDC is allowing mix and match. In other words, you can be boosted with whichever vaccine you want after you receive an initial series of another vaccine. I tend to recommend that individuals who receive an mRNA vaccine get boosted with another mRNA vaccine. It doesn't really matter if it's Pfizer or Moderna, it's whatever you find available. So one of the risks that has been identified with the mRNA vaccines is myocarditis and myopericarditis. There's a much higher risk of getting myopericarditis after getting COVID. The risk is probably 15 times higher when you get COVID than when you get the vaccine. Myopericarditis after vaccination is actually a very treatable condition. People recover quickly and rarely leads to hospitalization, and it has not led to death in any case. Unfortunately, there's a lot of misinformation out there about the impact of the COVID vaccines and fertility, and there's absolutely no data to support this claim. In fact, there's data that we have accumulated showing that there's absolutely no risk of giving the vaccination during pregnancy, giving the vaccine to lactating women, or giving the vaccine in future fertility of individuals. The one thing we do know is that pregnant women are at much higher risk of getting severe COVID than non-pregnant women. And it's very clear that those planning to become pregnant should get the COVID vaccine as a way to prevent them from getting COVID during their pregnancy. We will be back with more vaccine content, so be sure to like and subscribe and click on the notification bell to receive updates on when the next video will be posted.
Thanks, Jackie.
Bye.
And I am going to come back, I hope. Okay. So just so that everybody knows, information on boosters is changing very, very rapidly. And actually, there are some things I need to update from that video as we move forward. As the end of last week, January 25th, Pfizer is testing a new vaccine specific to Omicron, and Moderna has now announced the same thing. Dr. Fauci has said that this is an important resource, but that whether we will actually need to use these vaccines once they're developed is unclear. The other thing that you may have heard is the idea of a sort of universal coronavirus vaccine, since there are other coronaviruses over time that have caused severe disease. That is an interesting concept. We're not going to really talk about that today, but it is something to keep an eye on. It is probably years away from being clinically practical. But the heads up on this is that the recommendations on the numbers of boosters and the types of boosters are going to continue to evolve over the next several months and possibly years, and everybody should just be aware of that. And I think it's important to expect things to change, because I think one of the things that has been so unnerving is how rapidly things have changed, which is unfamiliar to many of us in healthcare. So things are changing quickly. There's a good system out there for monitoring what's going on. And I have a lot of confidence in the people who are working on this. And I'm delighted that they're working on communicating a little more clearly. Okay. So I do not know why. I'm sorry, we're going to have to see why we can't get to the next slide. Jackie, oh, there we go. Okay. So let's look at some common concerns and some related facts about COVID vaccines. And basically this slide is just some resources which you all have sent out to you. Just as a general rule of thumb, certain agencies like the CDC, the FDA, the NIH, which is the National Institutes of Health, state health departments, and people and healthcare facilities that you know and trust are generally really good sources of information. Harvard has a lot of really nice information, as does the Mayo Clinic, for example, but so does the CDC, the FDA, the NIH. It does take some practice to navigate through these sites, just because there is so much information, but they do get easier over time, I promise. If you are using statistics because you want to understand what's going on, just try to pick one or two sites and stick with them, because the sites don't always report exactly the same thing. And so if you sort of say, you know, yesterday this number was 103 and today it's 72, it could be that there's good news, but it also could be that you are comparing a rolling average, which is what many of the sites report, versus a daily number, and they will be different. So I strongly suggest that you find a site that you like and stick with it, because it'll be easier for you to see patterns over time. I really like the COVID Act Now site, which is referenced here. That one is basically a rolling 7-day average. And I like that because if there's a problem with data from one day, it gets kind of smoothed out so that you get really, I think, more of a sense of what's going on than if, you know, somebody forgot to report any labs for a day. So you think there's no COVID. And then the next day there's a lot. So I like the average. Let's talk about safety. And, you know, are vaccines safe? And the answer is, here's why we think so. And the other question that I sort of bring up in another slide is that we're not comparing getting a vaccine to doing nothing happening. We're comparing getting the vaccine to getting the disease, because that's what the vaccine is supposed to prevent. So if you look at this, between December of 2020 and December of 21, 469 million doses of the vaccine were given in the US. These are US numbers. And of that number, 0.0022% of people have died after receiving a vaccine. But what you also need to understand is that does not mean that those people died from the vaccine, because any patient who had received a COVID vaccine before they died from anything else, for example, a car accident, would be included in this number. So the number of people that have died from a vaccine, if at all, is a tiny, tiny, tiny number. And the number of people who had died from COVID in the United States and this number is tragically much higher now, was 838,000 people as of about 3 weeks ago. So the vaccine is much, much, much safer than the disease that it is supposed to prevent. And that really, I think, is the question that most of us should be looking at. This looks at US COVID deaths by vaccination status, and the much higher number is the unvaccinated number, and the much lower number is the vaccinated number. And it's just an easy graph to see that people who are unvaccinated die at a much higher rate than people who are vaccinated. One of the questions that's come up, and there have been several, is whether the COVID vaccines were developed too quickly and how that happened, because usually vaccines take years. And I actually found this explanation for myself really helpful and really compelling. So one of the things to remember is that although messenger RNA vaccines are new and new in this context, that particular tool using mRNA in various vehicles to do something, there's been research about that for the last 30 years. So this was taking technology that people had been working on and studying it, reapplying it in a slightly different way, but it was not by any stretch new technology. The second thing to know is that there are 3 testing phases that are required for all new drugs, and all of those were done. The thing is that a new drug has to pass all 3 phases. So typically in drug development, those are done sequentially. So if a drug doesn't make it out of phase 1, there's really no point in doing phase 2 or phase 3 because it's not going to be approved. In the case of the vaccines, because of the urgency, because of the pandemic, all 3 phases were still done, but they were done in overlapping fashion. So basically, there was a financial risk inherent in moving this process along without making sure that the first phase was complete before you did the second, but there wasn't a change or a decrease in the number of phases or the number of testing. The FDA still did its full approval process, and you will note that not everything got an okay. So vaccines for younger kids, meaning under 5, that was not approved, even when it was proposed. So this is not an automatic rush through approval situation, and everybody should be aware of that and comforted by that. The other thing is that some of the vaccines were manufactured before they were approved, so that if approval went through, they were ready. Typically, a drug company doesn't make a huge stash of a drug that they don't actually know if they're ever going to get to use. And you should remember that the plan was if these vaccines were not approved, they would be discarded. So again, this was a financial risk that was taken on because of the severity of the situation and taken on basically by the federal government, which means basically by us, which is why drug companies, were willing to do this in this way. But those are very big differences and explain to some extent the rapidity with which this was done. The other thing is that there are a number of ongoing safety monitoring programs. There are many, many systems in place. And and I'm going to give you an example shortly, that as there have been more people getting the vaccine, as you would expect, we get more information about rare side effects. And that does change the advice. And that is why J&J is less favored now, because there was a very, very rare side effect, which was the clotting situation. It appears to not particularly be associated with the others. It is dangerous. And as that became clearer, that's one of the main reasons why J&J is disfavored. There are other questions about COVID vaccine safety. And 2 of them have been, are there long-term or are there serious side effects? So the answer is yes, but they are very, very rare. There's been in general 4 major types of serious vaccine reactions that have been described. The first is anaphylaxis, which is, as you know, is a sort of urgent, sudden allergic mediated reaction, and that is treatable. The second is the clotting situation, primarily with J&J. It is very rare, but it is serious and it is not a problem with the others. And somebody who has a terrible debilitating stroke will obviously have very long-term sequelae. So that particular issue has affected vaccine advice, and more has been learned as we've had ongoing safety monitoring. The pericarditis myocarditis thing you heard about earlier on the video as well. And as my slide says here, it's much more common with the disease itself than with the vaccine. Since this slide's been written, there is some updated information, which is that the myocarditis, pericarditis clinical scenario that you get after the vaccine is somewhat different from the natural one that you get for other reasons. It comes on faster, it's less severe. People tend to recover, but it has a slightly different timing concept. And it seems as if this may actually turn out to be a little bit more common than was originally thought. If you look at how the vaccines have rolled out and you look at who gets this side effect, which is typically younger men, that's a group that has been getting more vaccinated more recently. So it's perhaps not really surprising that we'll see more cases of that as the target group gets more vaccinations. The advice is still that it's very clear that it is better to get the vaccine than not, but the numbers are changing a little bit. So I did want to bring that to your attention. And finally, the last one is Guillain-Barré, which is, affects the nervous system and has been associated with some vaccines in the past. At this moment in time, although Guillain-Barré has been reported after COVID vaccine, the rate at which that happens is not different from the natural rate of the disease. So at this point, although there have been cases reported after vaccine, it's not clear that those are vaccine related. And so I think we'll get more information about that over time. So I think the bottom line is that, there are side effects. Some of them are short-term and unpleasant, as you know, but that overall these are extraordinarily safe. And even after the hundreds of millions of doses, that still seems to be clear. Are vaccines safe and effective for children? Current data says yes. Should pregnant women get vaccinated? Yes. Are vaccines associated with infertility? Can they make you infertile? The answer to that, as you heard earlier, is no. There has been some recent data that women's periods may change a little bit after a vaccine, but that is probably for about a 24-hour period for a month or two and does not felt to have any clinical significance with regard to fertility or anything else. The other thing that I would mention is that there have been some reports of sperm counts declining post-COVID, but not post the vaccine. Not clear yet if that has any clinical significance, but if there is any data on infertility, so far it affects the men and it is with the disease, not with the vaccine. There's probably will be more information about that over time. And finally, I put this one in because when I was rehearsing, my son said to me, everybody keeps asking this question, although it wasn't on the CDC's list about safety, but can the messenger RNA vaccines change DNA? And the answer is absolutely not. And if you want to know why, it's because your DNA is in the nucleus of your cells and the vaccine doesn't actually ever get there. But apparently there are people who still have that question. So thought I'd throw that one in. It's difficult to address vaccine concerns, especially because this is very emotional for a lot of us. And so I'm going to turn this back over to Jackie to share two videos, again, from the ACP series on two physicians who talk about basically how they kind of talked about this, thought about this, and shared it with their patients. So I hope you find it helpful and interesting.
And I am a practicing internal medicine physician down in rural Albany, Georgia. I want to talk to you about my journey from being hesitant about COVID vaccines to being a COVID warrior. I was very skeptical about the vaccine when it first came out. I was like, this came out kind of quickly. Have they studied it long enough to determine what the side effects are going to be? It was important for me to read about it. So I went and found the same data that the FDA was given from the different vaccine companies to look at their research. I knew how to read research data because I had worked at NIH for 5 years. So when I looked to see how well the research was actually conducted, that even though it was done in a shorter period of time, I discovered that we have been working on these messenger RNA vaccines for the last 20 or 30 years or so. This did not start in December of 2020. All they had to do was plug in the genetic information for SARS-CoV-2. They already knew what SARS looked like. They already knew what MERS looked like. They're both cousins. thousands of this current virus. They already knew what to do. They had already tested vaccines and other clinical trials for influenza and rabies and other things. All they had to do was just plug it in. So as far as that goes, I don't really have any concerns with that anymore. The way we conduct clinical research now, the safety protocols that we have in place, the fact that you can't just do research on people any kind of way you want to. I mean, and around the world, the way clinical research is conducted has been developed to prevent the type of thing that happened in the Tuskegee studies. When I looked to see who had done the research, there's a young lady named Kisnikia Corbett, who was one of the original scientific leads on Moderna at the NIH. You know, and I like to tell my patients that African-American woman helped develop this vaccine. You have a right to want valid answers. There's so much stuff out there. You should not just rush into taking a vaccine or any medicine if you are uncertain about that medicine. It's okay to be concerned and to have questions. You know, as physicians, we're not here to judge you because of that. I don't like shots. I am a baby when it comes to shots. I took my friend with me to hold my hand. I got on board with the COVID vaccine because I felt like the risk of having COVID is a much greater risk, one, of developing COVID, and two, of having some serious symptoms and side effects from it compared to having the vaccine. I looked at what the FDA looked at. It changed my heart completely. Do you want to risk rash, sore arm, low fever, or would you rather risk being hospitalized on a ventilator and even death? So here they have a vaccine that they know is safe. They know that it works. What are we waiting for? We have something that works. Be a hero. Take a vaccine. Please subscribe to our channel, and please look for more from the ACP, the American College of Physicians, in the near future.
Ready for the next one, Lynn?
Yes, please.
Hi, I'm Dr. Keith Ferdinand, cardiologist based in New Orleans, Louisiana. And today we're going to answer your question about COVID-19 vaccination. I can understand someone who doesn't want to get vaccinated because they say, well, it's not 100%. But here's the reality. Persons who are vaccinated have a markedly decreased chance of becoming very sick or being hospitalized. People who are unvaccinated are 11 times more likely to die from COVID-19 than those who have been fully vaccinated. If you unfortunately caught COVID a few months ago, you may be protected for a short period of time. But we know this time the ability of COVID-19 infection to protect you from future infections starts to diminish. If you've gotten COVID-19, you should still get the vaccine. You know, I can understand a person who is pregnant being concerned about getting the vaccine. But here's the reality. Persons who are pregnant and are infected with COVID-19 have complications.
Are we okay, Jackie, or? Okay. Well, I think the computer gremlins may unfortunately have gotten in the way of seeing the rest of this video, but we will send it to everyone.
Crap. Sorry. That's why I got two computers going.
Okay.
Um,
Well, we'll just go back to the rest, and it's okay.
okay.
We'll send everybody the link because who knows what mood the gremlins are really in. So thanks, and we'll go back to our PowerPoint.
Okay.
So what we really want to talk about, you know, and what these videos are a lot about is how do we talk about vaccination in general, but specifically about COVID, which seems to have a lot more baggage around it. And the bottom line is that there's no point in being angry because it doesn't work. So, you know, it's tempting. Sometimes you just kind of want to shake people, but you can't because it doesn't work. And so these are some of the suggestions, and they're not always easy, but they do work better. So it's important to listen respectfully to people's concerns. Sometimes they're not what you think. You know, I had somebody come to the house who didn't want to put on a mask, and we're chatting about vaccines, and he was like, no way, not a patient, just somebody. And it turned out his father had died a few days ago and had just gotten the vaccine. And the two events were unrelated, but they were not unrelated in his mind. And you know, you'll hear those stories. And so sometimes understanding where people are coming from can be helpful in responding. You should always answer honestly and with facts. And you should understand the barriers that patients face and others face, and try to present solutions. You'd be surprised at some of the stuff that happens with our patients. And we'll go into a few of those details in a few minutes. Understand people's customs and beliefs, but realize that being respectful doesn't mean that you have to agree with something that you know isn't true. So being respectful does not mean validating things that are incorrect. Be a trusted advisor, or find a trusted advisor for the person if it can't be you. And understand when you start this that not every conversation is going to change minds. And that's a hard message, but it's an important one. These are the reasons that anger doesn't work. It doesn't change too many people's minds. People really stop listening for content once things get angry. And finally, you don't want to have a conversation where you're trying to do good to mess up important relationships, which could be family members, but also in our case, could be those between healthcare providers and patients. You know, we have other things that are important to do for patients besides COVID, and we still want to be able to do those things. There are a lot of reasons that people refuse vaccines, and most of you know them, but just to go through a few. Fear, that's often driven by the misinformation that is just about everywhere. The current political situation that has made vaccination a political issue rather than a medical one. And I don't remember anything ever in my career remotely like this. Even HIV did not seem to have the same drama that this does. People sometimes are just unable to change an entrenched position, especially in the political context. Sometimes people, as I mentioned earlier, ask the wrong question. So they say, well, you know, I can get a side effect from a vaccine or a pill or whatever, and that's true. But you also have to compare that not to doing nothing, but to getting the disease or not treating the disease that you're comparing this treatment to or this prevention to. And so I see that a lot. Clearly, in this scenario, rapidly changing information is difficult to understand. And if it's hard for all of us, imagine how it feels to our patients, and especially to those who might be kind of nervous and perhaps not as trusting of some of the sources that as some of us are. And that relates, of course, to the ineffective and inconsistent recommendations that we've been hearing. I think that message has been heard, that we need to do better about clear, consistent messages and advice, even from the experts. And I'm hoping that we'll see some improvement there. Some of the other things that are reasons that people don't get vaccinated that, you know, just make you sort of say, huh? And some of these are very much related to the health equity issues that are priorities for us at VIM. So here are a few of our top favorites. Okay, patients often need a computer to schedule a vaccine appointment. You know, in the past, there have been pop-ups and walk-ins and all of that, but the vast majority at the moment seem to be scheduled appointments, and you need a computer to do that. And you can't actually, most of our patients do have phones, that's absolutely true, but that you need an email to schedule an appointment. And so many of our patients, even if they are reasonably computer literate or internet savvy on their phones, still can't schedule a vaccine appointment. And that's been an interesting one. Patients fear the cost of treatments. And we had a patient who was at risk and COVID positive, who was initially offered monoclonal antibodies and refused them because somebody at that site told her that these were very expensive. And of course, they're not in various situations. Patients can be very worried about their legal status and their immigration status. And I can't tell you how many times I heard, especially in the early days, but these aren't okay for immigrants. And of course they are. People just in general may be afraid of vaccines or new treatments. And there are a lot of people that just don't do needles. And that is a really big barrier for some. And finally, limited transportation can prevent patients from accessing vaccines, depending on where this is rolling out. And this was a bigger problem early on. Now with the pharmacy availability, things are a little bit better. But these are real. And I'm sure that all of you that are on the phone have seen one or more of these. So hopefully we at VIM can make a difference here. And I'm really proud of the team, because I think there was huge outreach, and I think we really did make a difference in a lot of these areas. So how do we talk about vaccination barriers? And I want to thank one of my colleagues, Anne-Marie, who put this together. But, let's make sure that if a patient can't make an online appointment, we do it for them. And if you can't, find somebody who can. Help people get the transportation. If we can get people where they need to go, we have a much better chance of their getting vaccinated. Remember the fears that people have, and remember that they are safe from ICE when they get the vaccine, that public policy is that everybody, no matter who they are, getting vaccinated protects everybody else. But sometimes patients don't believe that. And be, as Anne-Marie said here, and as we said earlier, just common sense. Ask questions and try not to confront people, rather try to engage people and talk about what their needs are, and let them tell you stories and you respond to stories, and try to kind of take the temperature down. And that may be a more effective way to have these conversations. A lot of the information that I gave you above comes from these links. And they also lead to a lot of other places if you want more original references, and you will have this. So it's not just vaccines. There's a lot of other stuff to talk about, and that includes the following things that you all know: masks, ventilation, distance, isolation, quarantine, tests, and treatment. And I'm going to zip through some of this because I think you know it, but let me know if I'm too fast somewhere. Okay. There's a lot of questions about masks. Should I wear one? When should I wear one? What should I do? How do I know which way is up? All totally fair questions. Should you wear a mask, and when? And the answer is very clear. When community spread is high, wear a mask. You don't know what you're walking into. You don't know who's where. Wear a mask when you're indoors in spaces with people whose status you don't know. And I think that some of this is going to change and evolve, but that's my bottom line message. If it crosses your mind, you should be wearing a mask, you should probably be wearing a mask. How do you know which masks to wear? And there's been a lot of back and forth about that, and who should wear an N95, and what's a KN95, and are cloth masks okay, and what about surgical masks, and what am I going to do? So the CDC says now, wear a well-fitting mask that you'll wear. And for those of you who've been fit tested for an N95, you might have some real doubts about whether somebody will actually wear one of those all day, and because they're not comfortable. And I think that's true. So when you think about what mask you're going to wear, it's the mask that you will wear, and you should think about where you are. So how risky is the place you're going? How crowded? How at risk are other people? How likely are you to get exposed to COVID, and how worried are you about giving COVID to somebody else? And all of that should inform your choice of mask, because I think that what most of us are going to do, and I'm talking about in a personal setting, not the clinic setting, is you're going to wear the mask that makes sense for where you're going. And I think that that's going to continue to change, and that's going to continue to be something that you're going to need to think about probably for the next several months. Does that make sense? So it's hard to find reliable information on masks. And a KN95 is a mask that was not manufactured in the US and doesn't go through the same testing standards. But some of those earlier had emergency use authorizations, some did not. They're all over the place. Estimates have been as high as 60% of masks that you find online are fake. And, in meaning don't do what they say. So the resource here is some of the lists and some of the information that FDA has made over time. And the YouTube video, which I was debating going back and forth and showing you this, but it's basically how to put on some of these masks and how to do a seal test. And I would advise everybody to take a look at this, especially before you go back in the clinic. Now, when you do come back to the clinic, we are going to have N95s, I believe, available. Or if we can't get those, although we think we can, KN95s, we will still be wearing face shields for the moment, and there will be surgical masks available, although those are not considered as protective. What we will not be able to do, okay, is to do a fit test. And so when you put that mask on, it's going to fit really tightly. I'm asking you to watch the video to make sure that you put it on, follow the directions. And just as a quickie, if your glasses are fogging up, your mask isn't on right. Okay, so please look at the video later. Please understand that there are different kinds of masks and that the one that you are going to wear is probably going to depend on what you're doing. And that's okay. All right, you also know about social distancing, ventilation, and possibly HEPA filters. So yes, those are good. Let's talk a little bit about isolation and quarantine and what's the difference. So isolation applies to somebody who knows or thinks that they might have COVID. And given that there are some questions about tests right now, if you've been exposed to COVID and you don't feel well, you need to treat yourself like you have COVID. Okay, regardless of what your home test says. So when I say someone who knows or thinks they might have COVID, that's what I'm talking about. The CDC guidelines have recently changed, and a lot of people are confused and concerned about that. And remember when I said earlier that public health people look not just at the individual patient, but at the big picture. So when the CDC put this new 5-day isolation period as the bare minimum, what they were looking at was the impact on global society of different time frames. And they were thinking about the fact that Omicron, which was and is the dominant variant right now in the US, comes on quicker than some of the others and tends to be less severe. So they factored all of that into this discussion. However, if you read the small print, there are studies that predict, because they were modeling studies, that 31% of people are still infectious 5 days later. So what I think you need to consider is, assuming that you have the choice, do I think having a 31% chance I might still be infected, does that mean to me that I should just still jump out of isolation? Or do I think that maybe given where I am and what I'm doing, I might want to isolate myself a little bit longer? And that's really the big debate. So these are minimums, and they are taking into account the global picture. But that doesn't necessarily mean that it is the right thing to do to come out of isolation at day 5, particularly if you're someone who has choices. Even people who are coming out of isolation at day 5 should be very, very aggressive about wearing a mask for another 5 days of the remaining 10. So, you know, that, I don't know if that makes it a little bit clearer what the debate is, but that's really the underlying information about the CDC. And I would look at this as a minimum. And if you are able and think that you should do more to protect others primarily, I would suggest that you do so. But that is kind of the context for that recommendation. Is everybody clear on that? Pretty good?
Yep.
Okay. In terms of quarantine applies to somebody who was exposed to but not diagnosed with COVID. But what I would point out to you is that when we're saying this and recognizing some of the testing issues that I'm going to tell you, if you're not feeling well and you know you had a really good exposure to somebody, it's really the responsible thing to do to treat yourself as if you have COVID until you know for sure otherwise. Okay. Now, if you're not in that scenario, so you had a possible exposure at work and you're totally fine, you do not, if you are fully vaccinated and the proper terminology is now up to date, okay, then you do not have to quarantine unless you develop symptoms. Now, up to date means that you have had all the COVID shots that somebody in your situation is supposed to. So if you are an adult who is not immunocompromised, who got a messenger RNA vaccine, you are up to date at this moment in time that we're talking. If you had your 2 initial vaccines, which was your primary series, different if you're immunocompromised, but for most of us, And then if you are 5 months later, you got your booster. Okay. If you had J&J and you are 2 months after that shot and you got a booster with something else, you are up to date. And those recommendations or those definitions may change, but right now, the proper terminology is up to date. And if you are up to date, you do not need to quarantine, but you should wear a mask and then get testing down the line. People who are not up to date on their COVID vaccines should quarantine for 5 days after exposure, and then they should wear, masks for another 5 days. Now, for most of us, given how high community spread is, you should be wearing a mask anyway, but it's just something to think about. Now, quarantine for household exposures is complicated, and especially if it goes through the house, because the bottom line is that for people who need to quarantine, their counting starts on the day that the last person who was sick comes out of isolation. So if you have 3 people in a row and you don't get COVID for sure, at which point you become a case and that counting is clearer, your 5 days of quarantine start when the last person comes out of isolation. So if it looks to you, if you're looking at this and saying, oh my goodness, I could be quarantined for weeks or even a month, the answer is yes, which is a really, really good argument for getting up to date with your vaccine, because then you won't have to quarantine. All right, is that clear? Because this one's been hard for a lot of families. Okay. There are COVID tests that are now available, and you have the link there. Probably most of you know that. So let me just go a little bit into the tests, what's available and what some of the strengths and limitations are. Okay. Antigen tests test for a piece of the virus. Many, but not all, okay, important, home tests and rapid tests are antigen tests. Most of those tests probably stay positive 7 to 12 days, but there's a range. And in general, sorry, the dog's very excited about this. In general, people need a higher level of virus to test positive. So negative tests can be false negatives, especially early in the course of the disease. This may be a particular problem with Omicron and with nasal swabs, because it seems like Omicron may be more predominant in the mouth and the saliva early, but as long as the tests are nasal swabs and the rules haven't changed, you need to do the test the way it's directed, and there may be a higher chance of a false negative early on with Omicron. If your antigen test is negative, but you know you were exposed or you have symptoms, you should repeat the antigen test in a day or two or get a PCR test, which we're going to talk about in a moment. PCR tests are generally more sensitive, but one of the challenges is when you get the result back. If you're sick and you're exposed and you do a rapid test and it's positive, assume it's right and just act accordingly. There have been some reports of false positives. They are very, very rare. And in some of the biggest ones, they were traced back to a particular batch of the test, and it clearly seemed to be a manufacturing issue in one that was reported. It is very rare, although not impossible, to have a false positive. If it's positive, it's positive. As you know, there was a lot of controversy about why people do not have to have a negative test to come out of isolation. And the reason is that the tests were not designed to figure out whether when you have a positive test, you're still infectious. Because since they just test for a piece of the virus rather than for the full infectious virus, you might not be. And so that discussion is going to evolve over time, but that's the reason that the CDC and the scientists were really objecting to requiring a negative test. That was the backstory for that, because they weren't tested and approved for that function. Okay. This shows you, this is just a timing result, and it shows you that PCR and antigen tests can detect viral loads at different points. And in general, the viral load, of course, is low when you are initially exposed, then it goes up, and then it's low when you get better. And so the PCR is going to test things on either end of that further. And that's important to understand. NAT tests stands for nucleic acid amplification tests, and PCR is a kind of test like that. That's mostly the word that we use. Those tests can stay positive for months. So expecting someone to have a negative PCR before they can resume their usual activities is inherently problematic. They can be more difficult to get. They can take a while to come back. And so even if they are the more sensitive test from a practical perspective, you may just not be able to do that. There are some home tests that are NAT PCR tests. Most of them are not. It's important to know which one you're doing when you want to put it into context. Antibody tests. This is my particular hot button. And so I very much appreciate the evil picture that he put in. The reason is that these tests have been very, very, very heavily marketed. But the bottom line is that they are not useful for clinical decision making. And so I think a lot of people think these tests can do things that they cannot. And so unless you have a very particular reason to get this, you're in a clinical study, you're doing something like that, I don't think they have any reason or any utility to most of us in our day-to-day. So I do not recommend that you get one. It does not tell you whether or not you can still get COVID, which is what a lot of people were looking at them for, and it just doesn't do that. So this is a hot button for me. There are others who might disagree, but I would not make any sort of personal decision about my healthcare or that of my patients based on an antibody test. Okay, we're going to talk a little bit about treatments and just sort of what's out there, but I want to stress that these treatments are there. Some of them are really good, but that it's really important to realize that not getting sick at all is better than hoping that a treatment works, or quite frankly, that you can get one. All right, so monoclonal antibody treatments are intravenous. They can be given to people with mild and moderate COVID to prevent progression of disease. And if you receive this, and this is important, especially with patients, you have to wait at least 90 days to get a COVID vaccine if you're not up to date. That is not true if you have natural disease. But for monoclonal antibodies, if that's what you were treated with, you need to wait to update your vaccine. So that's important. They should be given within 10 days of when your symptoms started, and typically a positive test is required. They can be given in outpatient infusion centers. And the thing to remember is that previously there were 3 licensed monoclonal antibodies under emergency use. At this point in time, there's only 1, which is sotrovimab. And the other 2, as of 2 weeks ago, their emergency use were withdrawn because they don't work against Omicron, which is the most predominant variant. Some of you may have seen a battle in Florida over this because Florida was still giving the vaccine, the antibodies that probably didn't work, but license has been withdrawn right now. And if a variant comes back where they seem to work, they could very well return. I want to be clear that there's nothing wrong with these treatments for the appropriate variant. It's just that what we have right now is not an appropriate variant. And because only one of the 3 is available, availability may be limited from a practical perspective. There are other treatments that are available. I'm just going to mention this quickly because the odds are you won't be able to get most of them. Pfizer's Paxlovid, which is a combination of 2 pills, is, if you had a perfect world, the first choice according to the NIH, but it's not widely available in the US. It has not been widely available in our area. Most likely you won't see that in use. Sotrovimab is the one that I mentioned that has been intermittently available in our local hospital systems, and I'm aware of at least 3 of our patients who have received it because they were high risk. Remdesivir is an outpatient, is available now as an outpatient infusion. People were getting it that way anyway, but it didn't have the proper licensing and approvals. It does now on a temporary basis. It is not in short supply, but it has to be done intravenously daily for 3 days. So it is inconvenient, but not impossible. It is okay to do it as an outpatient. And finally, the 4th drug, which is Merck's molnupiravir, is the last choice. Although it is a pill, it is less effective by a lot than the others. And unfortunately, that is the choice that is available or was available last time we checked in the pharmacies close to VIM. VIM physicians, and everybody knows this, are not currently prescribing any of these. The reason is that you need to have backup and resources from clinical pharmacy and other things, infectious disease that we don't have. And so at the moment, we are not prescribing these. And typically, in order to get them, a patient kind of needs to go to urgent care and get the test from someplace that's affiliated anyway with the ability. So it's not been a problem, but I just want everybody to be aware. These policies could change over time, but this is where we are right now. And finally, it was time for another cartoon, and I hope you're all enjoying it. What are VIM's current policies regarding vaccination of staff, volunteers, and patients? And I want to be clear that these, like everything else, are going to be changing. These are the policies that I make in conjunction with Dr. Middleton, who is, as you know, our infectious disease consultant, some of my others in the literature. So if you have a question or concern, the buck stops with me on this. And scary place to be, but that's where I am with a great deal of backup. So all VIM staff and volunteers must be up to date with COVID vaccines to be present in the clinic, period, end of story. And Governor Murphy has now made this a much easier statement because he's gotten pretty aggressive about this as well. All existing VIM patients at a minimum must have completed their primary vaccination series, okay, when the office is open to in-person visits. Generally, that is 2 of the messenger RNA or 1 of J&J, again, unless they're an immune-compromised patient who would have 3, but we have very few, if any, okay? And we will, of course, encourage those patients to get boosters. We are seeing that many of our patients were not as tuned into the need for boosters as they had been eager to get vaccines. But I think we've made some real steps forward with that, and there's major initiatives on that. Anybody who wants to become a new VIM patient must have completed their primary vaccination series prior to being seen for their first appointment. Although VIM is continuing telehealth, we will not see a new patient for their first visit on telehealth. And so if you're going to be a new patient, you're going to need to be vaccinated. VIM will absolutely assist any unvaccinated person, not our patient, that's fine, who wants to become our patient with finding and scheduling a vaccine. Because our goal is to get people vaccinated and to get people needing the care that they would like. All existing VIM patients who have not completed their primary vaccination series may continue to have telehealth visits when such a visit is consistent with maintaining the standard of care. So because that is still our obligation. So if, in the opinion of the VIM provider, the standard of care cannot be met by telehealth alone, the patient will be referred elsewhere or advised to seek ongoing care elsewhere until they're vaccinated or until the policy changes, if it changes, based on the determination of public health providers in terms of what's going on and our own internal team. So everybody clear on that? So the rule is stricter for the volunteers than it is for the patients, but not by much. And everybody must be wearing a mask, a good mask. Okay. Here's my advice today. It could change. Hopefully it's clear. First of all, vaccines first, okay? And as we're sort of talking through this, be up to date with your vaccines, all of them, okay? You just don't need to get a disease that you don't need to get, okay? If you're due for a COVID booster, get it. And don't wait. I can't tell you how many people we've seen or talked to whose vaccine was scheduled tomorrow. Only now it's not because they have COVID. If you didn't get your flu vaccine, get it. You can get both at the same time, but you don't have to. If you've had or have had COVID and you weren't up to date with your vaccine, know when you can get it. For most people, it's as soon as you're out of isolation, but with monoclonal antibodies, you need to wait 90 days. And sometimes our patients aren't sure. So that's important to check. So with that, hopefully that was helpful. And what we'd like to do is present some scenarios. And at this point, hopefully turn things over to you guys to answer. So this is scenario number 1. And you can read it, but JC is a 29-year-old unvaccinated female. She lives with her 43-year-old brother who just got a kidney transplant She works as a server in a local restaurant, and she has a 7-year-old child. So how would you guys handle this? Like, what would you want to talk about? What would you ask? What would you do? And I'd love for one of the nurses to step in. You're muted, Sue.
There we are. I'm not muted. Unmuted. I'm unmuted. The first question I would ask her is this, because you have to start with her. So in a non-confrontational way, I would say, can we talk a little bit about why you haven't been vaccinated, and open the door that way? Obviously, she has many, many reasons to be vaccinated. And depending on her answers, I would bring up the point, that her 43-year-old brother is immunocompromised because of what the medicine he takes, that she has a higher than average exposure because of what she does professionally, and that she has a child who, could bring COVID from school, but also is eligible for vaccination too.
Sounds good to me. Does anybody else have anything to add to that? All
I'm a
right,
big fan of the pros and cons list, for people who are unsure about this. I'm a big fan of saying, okay, well, let's do a pros and cons. What are the cons about getting vaccinated? And then you list the pros of getting vaccinated with them in conversation that's relative to their particular situation. And 9 times out of 10, the pros outweigh the cons all the time, almost all the time. And the patient or the person sees themselves in that scenario. And that's, I think, the biggest obstacle that we have is people are not personally vested in this, because COVID may or may not have touched their household specifically, or the person that they knew that got it, just had flu symptoms and everything was okay. She may not realize that the person that she knew that got it lived with their grandmother, and their grandmother got it and was hospitalized for it. So people are generally not present in their relationship to COVID because they don't understand how it physically affects them, how it personally affects them. That's the obstacle that I see most. This is something that happens to other people. This doesn't happen to me. It doesn't happen to my family. Nobody I know died. All of those conversations. Being able to make it personal and make them put themselves in the position of understanding how COVID would affect their lives has the best chance of actually bringing them around.
Yeah. I like the pros and cons
That's what
idea.
I found. That's what I found.
I like that too. We have a few more scenarios. Would you guys like to continue a little bit?
Sure.
Sure.
Okay. All right, then here comes number 2. And I like that pros and cons too, Emery. And I liked Sue's framing too. That was real helpful. All right, here's number 2. Anybody know this guy? LM is a longtime clinic patient who we all know well. He smokes, he's overweight, he works 60 hours a week at a variety of jobs in order to care for his family. His family's always been his priority, and his is a 3-generation household. He comes to the office after a long absence. So what would you like to talk about, and how would you start? And you guys need to remember, I can't see everybody, so just go ahead and shut it in. Oh my.
The first thing we have to say is put a shirt on.
Yeah, that's
That's good.
And shoes if it's appropriate.
And quit smoking.
and quit smoking, absolutely.
Or at least put the cigarette out while you're in the office.
Please, please.
And the beer while you're at it, but anyway.
Right.
Well, you can't start with his COVID vaccine status, obviously. There's a lot more things to plow through before you get that. You get to that.
So I got a question, Sue. If he walked in this week, or maybe actually 3 weeks ago, are you
Right.
sure that you wouldn't start with his COVID vaccine? I'm just curious.
I think the first question I would ask him is, hey, how you been? Where you been?
Fair enough.
And then maybe the third question might be, what's your vaccine status? Have you gotten COVID? Anybody in your family gotten COVID? You know, seems to be what everybody talks about anyway. But yeah, so I honestly don't know who this patient is, although perhaps I should. And what was the story?
I'm pretty
Well,
sure.
this is generic, but
Yeah, he's not
it
really
does
one of ours.
touchstone. Yeah, it does touchstone a patient or two, I think.
Yeah, I'm sure. Yes, but I think before COVID vaccine status, I would say, so what brings you back to see us? We've missed you. If whether that's true
Yeah.
or not, you have to say that. We've missed seeing you. We've missed seeing you. Can you tell me a bit about what's been happening since we saw you last? Because I'm sure that's sort of a loaded question, but it's more than likely the place you have to start, COVID or no COVID.
Yeah,
Because
for
there
sure.
are people too, not just people in need of a vaccine.
That's true.
No, I mean, seriously, sometimes I don't know about the rest of you, but I sometimes feel a little tunnel vision coming on, you know,
Oh God, yes.
you know, so I think your point is actually is very well taken.
Mm.
So how do you guys think this conversation would go? Like, do you think that this is someone who is not interested, you know, is vaccine averse, or do you think there might be other things going on here?
My guess
I
would be
don't
there's a
think he
lot of stuff
believes
going
in
on.
vaccine.
But
Say
he
that again,
works-
Marissa?
I'm sorry.
He works 60 hours a week. He's got a variety of jobs in order to take care of his family. And it says that's been his priority. So he may be he doesn't realize the importance of COVID. And right now he doesn't realize the importance of his own health. So I think we need to just chip away and start asking a lot of questions and find out what's really going on in his life and with his family, and take care of him and eventually get to the COVID questions. But I wouldn't, like Sue, I wouldn't start the COVID questions right away. I'd find out what's going on with him and his family.
And of course,
And,
you
and
never
bear in mind,
know.
think too, that whatever you find out might ultimately lead back to COVID.
Oh, absolutely.
Right, yeah.
Especially right now.
You
Absolutely.
know,
Absolutely. Yeah.
remember that you are going to have some sense of his feelings about COVID vaccination, because he's going to have been asked the screening questions before he ever got to anything else.
Yeah.
You know, so you depending on whether you do them or somebody else does, you may have some idea about that already. But I think you're right. You guys are really compelling, and that this, you know, this is a person, and that we need to remember that, you know, even in the midst of all the COVID pressures and drama. But if there was one or two things that you could do for him, I mean, what would your goal be for the end of the visit?
In relationship to COVID, you mean?
No, period. I mean,
Yeah.
I would have about 27 goals, but they're probably not realistic for one visit.
I think I'd assure, so at the end of the first visit, after all this time, I would try to make sure that the biggest issues that he's dealing with are addressed. So, you know, if he's somebody who, you know, is hypertensive and stopped taking his medication, that we order new meds, that we give him a blood pressure cuff, that if he's a diabetic and he stopped taking his med, make sure he's got a glucose meter. He's got prescriptions for meds, you know, we set him up for whatever he needs, you know, and that there's hopefully a follow-up appointment not so far down the line, so we can check back, because as we know, it's not easy to do this stuff at a visit like that. And, you know, you can certainly have that conversation about the COVID vaccine. And, you know, the other thing you ask is, you know, anybody in your family have COVID, you know, that sort of thing. But just to put out the biggest fires at the end of that first visit, and then try and assure follow-up within a reasonable period of time.
I would say that for me, if it was very clear, and sometimes it is in the first 12 seconds, that, you know, talking about COVID was not something that was welcome to him, and that it was going to interfere with everything else, then I would,
Take it
know,
off the
take it.
table. Yeah.
Well, except for, a sort of gentle suggestion at the end before I sent them to Anne Marie for additional, less gentle suggestions perhaps.
With the pros and cons, yeah.
But, it is also possible that in this world that help with getting the COVID vaccine is why he came. And he
Could
might not
be.
have actually said that, but given everything we know about him, he might absolutely have no idea how to navigate what was kind of a mess, even for savvy people. And so I would at least, I think, want to make sure that if there was a sense even early on that this was really important, because to me, it is one of the most time sensitive things we need to do, although there are a lot of other things that he absolutely needs. But I think, and if he his family's his priority and he's got all these other risks and stuff, it might be that he just couldn't get it done.
Mm.
Mhm.
Yeah.
But if he works 16 hours a day, can we talk about what time he have available to talk to us about his family problems, any issues that are preventing him from complying with doctor's visit, medications, and all that? And then we go into vaccine, what is the best solution for non-smoking, alcohol, and all that. Let's find out first, what is his main issue?
Right.
Absolutely.
What brings you back?
Brings you back.
And is he still working 3 jobs? I mean, it seems to me there is a lot of social issues here too.
Yeah,
that
and
really
also
need to be addressed
also
before
could be a language barrier too.
Yes.
That's true. We did not specify, so absolutely.
Mhm.
All right. Anything else for this one?
So I think for any one patient, when we're having a conversation, and obviously apart from the regular services that we're trying to provide to this gentleman, if we are having COVID conversations with people, it's really helpful to, in the very beginning, diagnose their level of COVID fatigue so that you know how to approach that conversation. Because anybody that is wiped out on COVID, you're having a different conversation with them than people who have questions about it.
Yeah, that's very
So
true.
assessing that is a really important part of that conversation.
Yeah.
I just want to add that I think it's important when you just read this little scenario that his driver and his motivation is his family. I mean, he's working those hours in order to support a big family. And rather than honing in on just his smoking or just his COVID vaccination status or his weight status, his ability to keep working to support his family depends on his ability to keep himself healthy. And I think that you do sometimes need to remind them of those links.
Yeah.
So.
And to your point, Jackie, one of the conversations that people sometimes recommend, I don't want to get my vaccine because I'm going to get sick, I'm going to have side effects. And you can't tell them they won't, because they might, and they might miss a day or two of work because they might. But that the odds of missing how much work they are likely to miss from a vaccine is way, way less than how much work they're likely to miss from COVID. And some patients have found that compelling too. When you say, sure, you might get a side effect, and miss work, and we get that, but we're trying to keep you working because that's important to you, which I think is a good point.
Yeah, very good point.
All right. I can't see all of you, so if any of you are waving or whatever, shout out because I can't tell. And otherwise, I will go on to number 3 if you'd like. We have 4. You guys, all right. So this is number 3. AD is well known to you. She's a 24-year-old diabetic who's always worked hard to take good care of her health. She's in a new relationship, wants to have a child. She's always followed your advice, but as of this moment, she hasn't received any COVID vaccines.
Oh.
What do you guys think?
I think it's a big conversation we need to have with her.
I also think this is a nurse conversation as opposed to an administrative one.
No, and you're right. You're absolutely right. She needs to have the conversation with a healthcare provider, probably first and foremost. And there's lots of reasons why, why a vaccine is, all of us should be vaccinated, but she should be vaccinated for many additional reasons. And again, like Lynn was saying earlier, sometimes, exploring why they haven't gotten to this point is probably the first part of the conversation. You can't assume that she's an anti-vaxxer, or whatever you want to call that. You can't assume that. And she may have some misconceptions. So kind of unpacking the box of, okay, let's talk about, do you have it? If you don't, talk to pros and cons, like Anne-Marie said. But in her situation, obviously there's many, many pros and not so many cons.
What do you guys think? Anybody else? Because this one is a really fraught one. I mean, people are terrified when they want to get pregnant, especially now. And so this one I think is a tough but very real and super important one, because her risks and the risks to her baby are so high.
Yeah.
So we will wish her well and presume that we were super effective in that conversation and that she's feeling, really good about it now.
Yeah.
And finally, we'll see this person. Okay, so PG is a 32-year-old who works as a medical assistant doing home care for frail elderly individuals. She's always been dedicated to her professional responsibilities, and she's also the sole financial support for her family. She's had 2 doses of the Pfizer vaccine, most recently 7 months ago. Notice the number. Her unvaccinated 4-year-old son was just sent home from daycare with a note indicating that he's a close contact of a confirmed COVID case. She calls you to ask you what to do, and what would you tell her?
Boosted.
So what rules apply to her?
I have to pull up those CDC rules again. So I gave her the right information.
So guess what? You actually don't have to, because eventually you will have to. But her son is a contact, right? So his rules, she is a contact of a contact. Okay.
And she's not boosted.
They're right, but their rules are different. So the rules for the 4-year-old, he's not vaccinated because he couldn't be, right?
Couldn't be, right? Yeah.
Right. So right now. So, that's easy, right? I mean, he's got a quarantine, end of conversation. Her situation right now, unless he turns positive, okay, she doesn't have to do anything because she's a contact of a contact.
Right.
So what would you tell her to do?
Monitor for symptoms.
Yeah.
That's one possibility. So here's another one. And, this is sort of tricky. Would you tell her to hurry up and go get her vaccine? And, I think that's really unclear. But if her son hasn't yet exposed her, and he, because once you're exposed, you should wait till you know what you've got. So that's sort of added, because my first instinct is, well, just go get the stupid shot. But that might not actually be really good advice. But it certainly is something you could think about for them. All right, so she calls and asks you what to do, and you say,
monitor for symptoms.
Yeah.
Monitor for symptoms. I hope your kid's okay, and wear a super, super, super good mask everywhere.
That's what I was going to say, is be more vigilant about your mask wearing and hand washing.
Right, and what kind of mask, perhaps.
Not a cloth mask.
Right. So 4 days later, her 6-year-old daughter is diagnosed with COVID-19. And now she's calling you for more information. Is this a different scenario?
Yeah.
Gosh, yes.
Yeah.
Gosh, yes. Okay.
Yes.
So now you would tell her what?
She has to quarantine.
Yeah. Or she has to isolate first. quarantine
The
next.
daughter has to isolate because the daughter has the disease.
Right,
She has to quarantine because
Quarantine,
she was exposed, but as
Right.
far as we know, doesn't have the disease.
right, yeah,
And then when
And-
her son gets it, then she'll have to add another. few
right,
days.
another layer, yes. And she could still go get her booster.
Kind
I
of
don't
unclear.
know.
Once you've been
Right.
exposed, we usually tell
Yeah.
people to wait because you don't want to get
Yeah.
it while you're,
Mhm.
although, people who have accidentally been vaccinated because they didn't know, have
Mhm.
generally done okay, but it's not recommended. So at this
Yeah.
point, we usually recommend people wait till they know. And
Yeah.
then you can get vaccinated again unless you're in, special circumstance, as soon as your isolation's over. So you do not have to wait all the periods of time people used to think you did.
Right, yeah. All right,
This is tricky.
it's a little complicated, yeah.
Keep those guidelines. And I'll tell you from a practical perspective, what I normally do is if somebody asks me a question, I usually pull them up because they change
do
so
I.
fast.
I know, yeah,
And,
yeah.
you also, depending on the context, the state guidelines don't always match the CDC. And
Yeah.
sometimes they don't update as quickly. What they've started to do now, at least in New Jersey, is say, we're getting around to updating our website. In the meantime, check the CDC and put
Yeah.
the link in. But they didn't used to do that, and it really was confusing. So I suggest people just update at the moment of the
Yeah.
question.
Yeah, yeah.
Because of the- Okay.
And employers don't always go with the CDC website either, because my grandson works for a school and his school is still insisting on a negative COVID test before they will allow people to come back.
Which
Makes
isn't
no sense.
necessarily needed, yeah.
My husband's a lawyer and I set the policy for the law firm, and we require 10 days of isolation because
Mhm.
most of our people could work from home with no problem.
Mhm.
And most of our people are in a risk group of one sort or another. And so we just
Yeah.
think the 31% chance of risking your colleague is too high. And
Oh, God, yes.
we're able to do other things. So yeah, I think I look at the CDC as a bare minimum. And again,
Mhm.
taking into account this other stuff. But the test business is tricky because it makes sense as long as the tests do what you think they do. It's just that they don't.
That's right.
But they're all we have.
But they're
what we
the
have.
best. They're the best we have. And so the question is,
Yeah.
which way do you want to err? So these are some really good, links to explore. And I would pick a couple that you like and then get used to them, because some of them are, to me, not totally intuitive to navigate. So if you kind of pick your favorites, you'll
Mhm.
probably find that a little bit more rewarding. So that's for this. And then, if there's any questions, but just remind you guys, these are tough times, but we are VIM strong, and we will get through this together, and we will take care of our patients and each other. And I wanted to thank everybody and for everything that everybody does, and just make sure that there aren't any other questions or comments.
Well, I have to run, but thank you very much. It was great and very informative, and nice seeing everybody's smiling faces again. So
Well-
I'll see you in the summer.
And thanks
Oh,
so
that'd
much,
be nice,
everybody. And if
yeah.
you need anything after, feel free to reach
I
out.
will.
Okay.